Good morning, and thank you again. I'm one of the rare non-epidemiologists here, so you'll bear with me. And I've been given the task to do a quick setting of the stage on this complex topic, so it will be rather fast, but don't be alarmed. There are lots of great presentations and speakers that will elaborate on the topics. So I come from the IOM. We are a multidisciplinary organization. I come from the Department of Migration and Health, from the regional office in Brussels. Our motto is healthy migrants in healthy communities. But to go back a little bit, why are we looking at migration? Migration is our legacy from DNA nowadays. As you know, we can trace the spread of humanity out of Eastern Africa. Of course, in the 21st century, migration is a megatrend. You know the numbers. It's important to mention that internal migration is still the highest, and so is south-south migration. And of course, migration is connecting us as individuals and our health. So the reasons behind migrations, I'm not going to go through them. You're quite aware of them in terms of pull factors and also the emergencies, the conflicts, the disasters. Recent figures show that 1 person per second has been displaced within their own country due to conflict, violence, climate change last year. And of course, the inequalities. So just a quick look of our world according to distribution of wealth, of human resources for health, of global refugee trends. So when we talk about migrant crisis or refugee crisis in Europe in the past few years, I think we need to be a bit more careful and have a bit of a perspective, because most of the refugees are hosted in poor settings. And of course, if we look at distribution of disease, we have a bit of a similar picture, and these are all also migration factors. So back to definitions, migrants for IOM, it's basically any person who is moving or has moved across an international border or within a country away from the habitual place of residence. And this is regardless of the status, regardless of the reason for migration, the causes of the movement, and the length of the stay. So we've chosen this comprehensive definition, which is people-centered, based on human rights approach, beyond, and it's quite important when we talk about health, because the status does not really, has some effect on health, of course, but it's important to look beyond that. So who are the migrants? We have, as I mentioned, different type of migration: forced migration, voluntary, circular migration, permanent, seasonal migration, and different categories of migrants. It's important still to stress that the vast majority of migrants are migrant workers. So if you add their families as well, we reach to close to 70–80% of people. That migrants accounted for 47% of increase in the workforce in the US and 70% in Europe over the past 10 years. So it's important to think about the contribution of migrants. Some definitions still, since that was the topic of my talk. So refugee is someone who seeks protection in another country because of fear of persecution for all these reasons. There are additional definitions that have come up, especially from the African continent, to elaborate a bit more on this definition. And asylum seekers are persons who seek safety from persecution or serious harm, but who are waiting their decision to have a refugee status. And actually, when we talk about refugees within the European context, we usually tend to talk about the asylum seekers with positive decisions, so the ones who have refugee status, because they then are entitled to similar treatment as nationals. You've also heard the term irregular migrants. We do not use illegal, because no human being can be illegal. It's usually these are people who are either entered unauthorized in an unauthorized way, or usually more often than not, the vast majorities are people who actually whose visa or work permit has expired. So within the persons in a regular situation, you have migrant workers, overstayers, stranded migrants, and rejected asylum seekers. Trafficking, also an important definition, is linked usually to exploitation. And again, it's distressful to see that even if slavery was abolished 150 years ago, we have much more people nowadays in slavery than any time in our history. And again, to stress that amongst the trafficked persons, the vast majority are trafficked for labor. Then, of course, it's sexual exploitation, domestic workers, and so forth. And another final, for now, definition, the difference between trafficking and smuggling. Smuggling is a service, so it's not usually, meant for exploitation, even though at the end, things are linked. And of course, it is poverty, desperation, and the lack of legal channels that force people to either use smugglers or get into traffickers' networks. So what about migrant health? There are lots of myths in terms of migration and health, that migrants carry disease, that they may be a burden to health system if you have generous health systems. But of course, the reality is quite different. Migrants are healthy most of the time. It takes a lot of stamina and courage to actually pick up, leave your country or place of origin and move. They usually underutilize health services because they also have other priorities for all kinds of other reasons. They're very diverse, as I mentioned already, and it is the conditions that surround the migration process that impact on health. And some of these conditions are basically, we need to look at the whole migration cycle. So from what happens at country of origin, during the movement phase, which is usually the most dangerous one, during the arrival, and we'll spend a bit of time in terms of factors that affect health during the arrival, and the return phase. And of course, the people who are at particular risk as the persons who end up in a irregular situation, asylum seekers, refugees, children, a lot of them, single parents, migrant families. So do migrants have the URI right to health? And in fact, the application of the right to health is guaranteed by multiple international treaties that all member states have signed, and by the principle of non-discrimination. So there is an abundant literature proving how member states are de facto committed by these instruments to provide healthcare regardless of status. For one, the principle of non-discrimination and equal treatment for all includes that the states must ensure that health facilities, goods, and services are available, accessible, acceptable, and of good quality, and that states are under the obligation to respect the right to health by inter alia refraining from denying or limiting equal access for all persons, including prisoners, detainees, minorities, asylum seekers, irregular migrants, to preventive, curative, and palliative services. So it's important also to note that the right to health is not the right to health services only. It's a much broader definition, and it looks at also access to other determinants of health, and we'll discuss, other speakers will discuss more about determinants later on. In addition, the right to health, all basically international rights instruments are interlinked, they're indivisible, and they're applicable to everybody. So there are linkages between health and other human rights. And basically, again, health is a fundamental right, and there are accountability mechanisms and effective remedies at international, national levels. So also to recall a little bit of the policy environment at global level, there is the World Health Assembly resolutions of 2008 that all member states have signed, also a recent one in 2017 related to the compacts. We'll talk about this later. We have the World Medical Association Declaration, which specifically indicates that every person is entitled without discrimination to appropriate medical care. At European level, we'll have the European also WHO Euro strategy, again adopted by member states. We have at the Council of Europe level, there are quite a lot, but just to mention the Istanbul Convention, which is the first legally binding instrument to combat violence against women, and again, it is applied to all type of persons, including regardless of status. The European Declaration of Health Professionals, similarly. And at EU, and there is quite a lot of documentation and policies, including the minimum standards for the reception of asylum seekers, which is again a legally binding document, which asks member states to ensure that applicants receive medical and psychological care. They're entitled to necessary, urgent, and pain-relieving care, and children for preventive services as well. The Lisbon Treaty speaks of the protection of human health as well as of values in terms of social cohesion and elimination of inequalities. And there are quite a few other resolutions. I'm not going to go through all of this. Last year, the action plan on integration of third country nationals specifically for the first time recognizes that ill health and lack of access to health services can be a fundamental and ongoing obstacle to integration. And there was a recent communication from the European Commission about the need for protection of children in migration, and in particular, again, also preventative services and the importance of having disaggregated data. So just a quick look at what happens at national policy level. You may be familiar with the MIPEX, the Migrant Integration Policy Index. It's a recognized common quick reference to understand and compare national integration policies in different sectors, but it's a way forward in terms of improving standards for equal treatment. So MIPEX measures equity between nationals and migrants, and you can see from this map that basically policies are just halfway favorable for integration within the EU. What we did with large collaboration is develop the health strand. So we developed 38 indicators for integration and equity. The benchmark was the Council of Europe recommendation to member states, again adopted by the 47. And it basically covers 4 dimensions. I quickly run to them. I'm sure we'll be discussing later on. So again, you have this quite disparate picture within the EU. All the reports are available, country and otherwise. So what are the elements that we looked at? We looked at entitlement, but not just whether a person is entitled or not. Are there obstacles? What type of coverage? And this for different categories. So alarmingly, this is the total rate for entitlements, and you can see that even legally residing migrants within the EU only reach 70% parity with nationals in terms of entitlements and policies, and there are quite a lot of obstacles. So disaggregated by different categories. For asylum seekers, this is the picture you have. The numbers are the numbers of countries. So we have 15 out of 30 countries within Europe that do not have conditions for access to healthcare for asylum seekers. 14 of those, it's coverage the same as nationals. The other half, it's emergency or close to emergency, but still there are quite a lot of administrative barriers. So you can also have the picture by the different countries, and basically the restriction of healthcare to only emergency rather than primary healthcare. Of course, it contravenes the principle of non-discrimination for one, but it also has costs, and that will be the subject of another presentation. There are several other elements in terms of the importance of and how to integrate, to facilitate integration. So these are some of the indicators, the type of information, are the policies around providing information, are there mediation, is there mediation that's provided? And again, we see a similar picture where in half of the member states, there is no mediation that has been, or policies around it. Of course, there are some initiatives, but in terms of national level policies or regional, it's quite disparate. In terms of the responsiveness of the health system, these are again some of the indicators, and involving migrants, encouraging diversity in the health services, in the recruitment, and again, a bit of a similar picture. These are the lack of basically policies at member states level in terms of training health staff in diversity or in migration, and we have done quite a lot of work in this field as well. And finally, some indicators, what will be needed to achieve change. And of course, one of the first one is about data collection, because politicians always want us to have the evidence, and this is some of the indicators, and this is the type of picture that you get. So basically, in terms of disaggregation of data by migrant status, we have only in 10 member states where this is mandatory for the data collection. And then you have all the other issues in terms of contribution policies about contribution of migrants to policy making. In terms of leadership by government, we have two. Basically, member states where there are migration health policies at national level or focal points. So more or less in conclusion, how do we realize the right to health in law and practice? We looked at all the obstacles. What needs to happen is clearly defining the entitlements. First of all, abiding to the commitments made within all these international and national level instruments. Defining entitlements, because basically when even within the EU minimum standards, basically there is language of urgent, necessary care, and that leaves a lot to interpretation basically. What is needed is to ensure appropriate implementation measures, to reduce the bureaucratic and the complexity of the procedure. Communication, of course, is important. So it's crucial not to condition provision of health care to immigration status, and also to provide protection and assistance to trafficked persons without linking it to whether they cooperate with law enforcement services, which is in most of the cases right now. So finally, or for now at least, why should we look at migrant health? Well, migrants have the right to health, so we need action to ensure that this right is upheld and that the universal health coverage and equitable access to quality health services is provided. In terms of irregular migration, we have developed an expert consensus on healthcare provision for persons in irregular situation, where we synthesize the human rights, the public health, and the cost arguments. Please feel free to further endorse it and popularize it. It's important to include, of course, migrants in health system because it improves public and global outcomes, to ensure appropriate health policy frameworks and programs are in places. And we feel that tools such as MediPIET can contribute in this direction. And of course, healthy migrants contribute to social economic development. We need to link and remember the relation with migration and development, and that the realization of the sustainable development goals, every single country is to report on. I keep repeating this because in Europe, sometimes people think development is for somebody else. The main tenet of the Sustainable Development Goals is universal health coverage. That means including everybody. And also there is member-stated commitment to leave no one behind. And it's important that we continue to work in this direction so that health of migrants is indeed accounted for and reported on. So thank you very much for your attention. Since we're in Greece here, a little example of good practice of how we taught over 28 centuries ago. So thank you again.
Thank you very much, Roumyana. 3-4 minutes questions. Anybody would like to ask something?
thanks for a very interesting talk. I had a question. What does the right to health actually mean?
I think right to what does it mean? I think it's more, as I mentioned, it's more than the right to health services. So basically, it means that, for example, if you look at, I mean, in a practical terms, it means that at the border, for example, a person cannot be member states cannot decide to prevent a person to enter because of health reasons. Of course, there are, examples and, exceptions, and you are better aware of the IHR, et cetera, et cetera. It also means that once a person is in the country, they should have the same type of health services as nationals, including, like I said, it's not the right to health services only, but it also to food, to housing, and so forth, all the other determinants. Now, of course, in practice, it's quite complicated. However, as I mentioned, there are instruments and there is jurisprudence where member states have been actually taken to court, which, how, and I mean, that not every person can do this, it's obviously also quite clear, but there are quite a few jurisprudence cases where member states have been actually accused or are made to provide health care for people who, for migrants, for example, where the case was brought to court. Well, we'll have plenty of opportunities.
Plenty of time, yes.
So thank you very much for your attention.